Okay, my name's Lucia Li. I'm a neurology clinical fellow at Imperial College London. I'd like to show you some work that I've done where I've used TDCS, where I've investigated the effects of TDCS on response inhibition. So first of all, I'd like to thank my colleagues without whom this work could not have been done, as well as my funders, especially Dr. Violente, who's also got a presentation of her own on Thursday. So TDCS, I won't bore the audience too much. It's a non-invasive way of electrically stimulating the brain. Typically apply 2 scalp electrodes, current flows from the anode to the cathode, and you can get a possibility of 2 stimulation polarities. In vitro studies have demonstrated that TDCS can alter the neuron excitability through a modulatory process. Anodal stimulation increases excitability, and cathodal stimulation decreases excitability underneath the electrode. It has been mooted as an attractive option for boosting cognitive function, with a few studies showing that in a range of conditions as well as controls. However, there is a big limitation of our understanding of its mechanisms of action in cognition, as well as limited understanding of inter-individual variation in response to stimulation. And this has been a big barrier to translation for the clinic. So, response inhibition. It's an important part of cognitive control, and I'd like to paint you through a little scenario. You're driving in a car that you know very well, on a route that you know very well, and you're getting a bit bored, you're thinking about dinner, when bang! In front of you runs a small child chasing a ball. At this precise moment, you have to switch from an automatic state, where you're sort of daydreaming, to a salient state where you notice the stimulus of the child, and hopefully you engage the brakes and not run this child over. In that moment, you are inhibiting your responses. In the lab, we measured this. In our lab, we measure this using the stop signal task, a pretty standard measure. So most of the time, you click left and right buttons to a left and right pointing arrow. This is pretty easy, pretty automatic. 20% of trials, you get a stop signal, this little red signal. This requires you to stop your response, to inhibit your response, as it were. The main outcome measure is the stop signal reaction time, or the SSRT, and a low SSRT indicates good performance and good response inhibition. So, how is this relevant? Well, during response inhibition, you see a characteristic pattern of activation and deactivation of brain networks. Typically, you see deactivation of the default mode network. That's the areas in blue here. Am I pointing the right thing? You see, it's the areas in blue, so the ventral medial prefrontal cortex, the precuneus, and posterior cingulate cortex. And you see increased activation of the frontal parietal control networks and the salience network. In the salience network, the node that I'm particularly interested in is this right inferior region here, the right inferior frontal gyrus and the anterior insula. This is thought to be particularly important in coordinating the activity of the rest of the networks. Good structural connectivity is required for this coordination. In fact, damage to this, the tract linking the right inferior frontal gyrus and the dorsal anterior cingulate cortex as a result of injury produces abnormal connectivity between the salience network and the default mode network, abnormal default mode network activation, and poor response inhibition. So this led us to question, first of all, if I stimulate the salience network, can I improve response inhibition? Secondly, does salience network white matter structure in that tract that I show you influence the response to stimulation? Thirdly, does stimulation of this one key node, is that able to modulate activity in a wider network areas? And finally, to what extent do anodal and cathodal stimulation have distinct effects? So we used healthy controls, 26 of them, and we used, I applied the active electrode to F8, so the right inferior frontal area, and the reference electrode at the right shoulder. Participants played the stop signal task under sham, cathodal, and anodal stimulation, separated by a couple of minutes, and this order was counterbalanced between participants. Whilst doing this, I acquired fMRI simultaneously so that I could study the action of the networks. So, results. Does TDCS modulate cognitive control? So, on the y-axis, you have the stop signal reaction time. I remind you that a low stop signal reaction time indicates good response inhibition. So, anodal stimulation significantly improves people's response inhibition performance compared to sham. You see a trend towards this with cathodal stimulation as well, but this is not significant in post-hoc testing. So, hypothesis 2. So, are we able... Points to the front. Okay, thank you. So, does white matter structure of the salience network influence response to stimulation? And does stimulation of this one node modulate the activity of wider networks? So we acquired DTI as well in these same participants, and particularly in this white matter tract that I've shown you before, connecting the two nodes of the salience network. And we split the participants into low and high FA groups, depending on whether they had an FA that was lower or higher than the median FA of the group. And what you see is this. In the low FA group, applying anodal stimulation does not do anything to their response, to their behavioral performance. However, in the high FA group, this is where you see the magic happen, as it were. You see an improvement in their response inhibition. This effect is specific to anodal stimulation. You do not see the same differentiation with structure with cathodal stimulation. Neither do you see this effect with when I separated the participants based on whole brain, FA, and white matter of the DMN, so the default mode network. Secondly, what is this stimulation of this node doing to the rest of the networks? So just looking broadly, anodal stimulation preserves the broad patterns of stimulation that you see with sham. However, if I directly compare the low FA group and the high FA group, under anodal stimulation, the high FA group have increased activation in the right anterior insula. Again, this effect is not seen with cathodal stimulation, and this effect is not seen with when I looked at FA of other white matter tracts. So, to what extent does anodal and cathodal have distinct effects? So looking broadly, cathodal and anodal both preserve the patterns of activation and deactivation that you see. However, cathodal stimulation, in direct comparison to sham stimulation, increases subcortical activation, particularly in the right caudate. And this is not an effect that we see with anodal stimulation. So, conclusions and further questions for discussion either here or at my poster. Salient network stimulation appears possible to modulate response inhibition and cognitive network physiology. But to what extent might this generalize to other tasks, stimulation of other cognitive networks, stimulation of the other node in the salience network? Secondly, the effects of anodal stimulation appear to be highly dependent on the structure of the underlying network. And why might this be the case? Finally, it has been well characterized in motor studies that anodal and cathodal stimulation can sometimes have a sort of opposite effect. This is clearly not the case, as I've shown in cognitive work. And I think this really needs further exploration, and we need to really investigate how the brain experiences polarity. So I will be standing at my poster on Tuesday. Unfortunately, due to clinical commitments, I can't be here on Wednesday and Thursday, so please come today. And I'm poster 1109, that's my email address. And my collaborator, Dr. Inez Violente, is also running a session on brain stimulation oscillations at Thursday, 8 a.m. It will be worth it.
We have time for one question.
Thank you for your talk. I have one question related to the last point which you make, and you showed in your sorry, my voice is a little bit. In your behavioral data, you showed that cathodal had also some effect. It was not significant, but of course you could clearly see there was something behind. So I was wondering if you go to single subject data and see, okay, we know because we know every subject behaves different. So how does the situation is there? Do you see a similar clear effect for anodal and cathodal, or is it more blurred? So what was your
If
experience?
only that were the case. So I think, as has been done quite well in a lot of motor studies, people have looked at this. You know, is it that the more likely you are to respond to anodal, the more likely you are to respond to cathodal? Is it that what you respond to the positive way to cathodal and anodal? You know,
Yes.
there appears to be not that much correlation, certainly in my study, and I think that's also been the case for a lot of motor studies as well. So that's why I really think sort of this combined imaging, you know, we really have to acquire some kind of biomarker beyond our behavioral data in which to interrogate, because currently, you know, we can't take this forward to the clinic, we can't take this any further because we don't understand the mechanisms, and I think this polarity issue is really, really important, because I'm sure they act by different ways, but not opposite ways.
just a short one. The high FA group, did they have a better performance in the task, or were there any differences in performance?
So the high FA group
compared to the low FA group?
Compared to the low FA group, yes, that's the whole point. So the high FA group under anodal stimulation have improved response emission, whereas
Yes,
the low FA group don't.
Yeah, but the general performance independent of the
Oh, I
stimulation.
see. No, so that was not seen for sham either.
All right, thank you.
Yeah, this is very specific to that tract to anodal. It's
Yeah,
kind of odd, but kind of cool.
Yeah, interesting. Thank you.
Thank you.